Hemangioblastoma by Harleen Gonzalez, Caitlin Chobanoff, Shimon Thomas, and Alexis Cowell.
Dr. Henry Mensch is a renowned neurosurgeon and author of the book Do No Harm, Stories of Life, Death, and Brain Surgery. This book inspired my group's research on hemangioblastomas and how it affects the brain. Dr. Marsh received his undergraduate education at the University of Oxford and went on to study medicine at the Royal Free Hospital School of Medicine.
Hemangioblastomas are the most common in the early and middle ages. It affects all genders equally. People at higher risk of developing hemangioblastomas are people with von Hippel-Lindau. The symptoms of hemangioblastomas all depend on where the tumors are located. Some common symptoms are headaches, imbalance, loss of coordination, nausea, and vomiting. Smaller tumors tend to have no symptoms, while larger tumors compress the spinal cord and cause numbness, weakness, difficulty walking, and bladder infections. Cerebellar symptoms put pressure on the cerebellum, which can cause hydrocephalus. Brainstem symptoms can cause a loss of motor functions and sensation in the extremities. It can also cause bladder infection. To determine whether or not someone has hemangioblastomas, an MRI and CT scan are used. An MRI scan is normally used for the scan of a brain and spinal cord. CT scans are normally used for the scan of a cerebellum and the brainstem. For planning the surgery, a spinal angiograft is performed. Spinal angiograft is the study of blood flow around the tumors. The outcome of hemangioblasts all depend on if the whole tumor is removed during surgery. 1/4 of hemangioblasts reoccur following surgical treatment. It is possible that it could cause neurological deficits. If you have von Hippel-Lindau, new lesions could form after the tumors have been removed. Hemangioblastomas cause the death of 82% of patients with von Hippel-Lindau.
The tissue type affected is made up of hemangioblast cells. Hemangioblasts give rise to hematopoietic cells, which develop as blood cells and vessels, and endothelial cells, which develop as endothelium. They are believed to be derived from mesodermal cells developed early in embryonic life. However, a recent study suggests that hemangioblasts are evident in the primitive streak, which is the earliest trace of the embryo that develops prior to the mesoderm. The formation of the primitive streak marks the start of gastrulation, the process in which the 3 germ layers are formed. Hemangioblasts then form blood islands of the yolk sac, which is a structure that is later replaced by the placenta. The blood islands are characterized by endothelial cells on the outside and primitive blood cells on the inside. This structure is depicted in these images in both microscopic and representational formats. The role of hemangioblasts is normally halted during early embryonic development. The hemangioblast cell is characterized by the presence of various cell surface markers. This image shows a cell surface phenotype of a hemangioblast and of the hematopoietic and endothelial cells it can differentiate into. The hemangioblast features the proteins CD34, VEGF, and CD133 on its surface. Vascular endothelial growth factor, VEGF, is significant because it stimulates the differentiation of an embryonic stem cell into a hemangioblast, thereby making the development of hematopoietic and endothelial stem and progenitor cells possible. Abnormal functioning of hemangioblasts can result in cancer. As mentioned before, the role of hemangioblasts is normally arrested during the development of the early embryo. However, under certain conditions, they can reactivate in adults, causing hematopoietic and endothelial differentiation to occur again. This sequence of differentiation is illustrated here. This can contribute to tumor development. While tumors are typically seen in the CNS, they can develop anywhere in the body that hemangioblasts may have been carried through, causing renal and pancreatic cysts, pheochromatocitomas, and carcinomas.
There are multiple areas of the brain that can be affected by hemangioblastomas. The most common place to develop a hemangioblast is in the cerebellum of the brain. If a patient is diagnosed with von Hippel-Lindau disease, which is a genetic disease, the areas of the brain include not just the cerebellum but also the brainstem and cord as well. The symptoms include headaches, nausea, as well as experiencing loss of coordination and imbalance. Experiencing loss of balance and coordination closely relates to the pressure caused by the hemangioblastoma on the cerebellum, which hinders the cerebellum's ability to integrate information. This then inhibits the production of precise and fluid movements of skeletal muscle. Treatment options vary between surgical procedures as well as radiotherapy. Patients that are in need of surgery can have various types of resections performed in order to completely remove or partially remove the hemangioblastoma. Another course of treatment for patients includes stereotactic radiotherapy, which is less invasive. One of the most common complications and fears of patients is the reoccurrence of another tumor. In this case, the patient should be tested to detect if they have von Hippel-Lindau disease. Although not mentioned frequently, polycythemia has been connected to having had a hemangioblastoma and has been known to play a role in the development of renal cancer.
When discussing patient outcomes, it is worth noting that because hemangioblastomas are so rare, current research and literature on survival outcomes is sparse. After 10 years of being diagnosed with hemangioblastomoma, the survival rate is 73%. Location is also a factor in patient outcomes, with hemangioblastomas of the cerebellum having better odds than those of the brainstem, those of the brainstem having worse outcomes and a lower overall survival rate. Age also is a factor in overall survival. Younger patients, those aged 40 years and younger, are more likely to have larger tumors that are multifocal and are more commonly on the brainstem. In younger patients, if they receive treatment or not does not assist in predicting survival outcomes. Race is also linked to different survival outcomes, with hemangioblastoma patients of Asian and African American descent showing shorter survival outcomes. The amount of tumor removed also helps determine survival outcomes. Gross total resections show better outcomes than subtotal resections and biopsies. These outcomes are all in the case of hemangioblastomas on the cerebellum. In conclusion, gross total resections produce greater survival rates, 91% at 5 years, than stereotactic radiosurgery and subtotal resection/biopsies. These two treatments provide similar survival outcomes, overall survival rate ranging from 85 to 89% at 5 years. The top 3 things my group learned. While benign, hemangioblastoma can lead to complications that can cause other cancers and health issues. We also learned von Hippel-Lindau disease, a disease that can cause hemangioblastomas to develop in the brain and cause multiple issues. Finally, we learned that hemangioblastomas arise from hemangioblast cells, whose role is inhibited in early embryonic development that become reactivated later in life.